welcome to another episode of the Face podcast. I'm here in Sydney and joined by Sydney-based plastic surgeon, Dr. Michael Miroshnik. Thanks for coming in today.
Thanks for having me.
So your parents immigrated here from the Ukraine when you were 7. You grew up in Sydney.
Yep.
Studying here, university, medical school. Yep. What was that moment where you thought, I'm going to become a plastic surgeon?
Oh, wow. It was a lot of years coming. I guess I came here as a kid, didn't speak English. We moved straight to Bondi with my parents, a lot of Ukrainian immigrants all through the 80s and 90s. And like most immigrants, they told me you have to be a doctor or a lawyer. And I was always very hand-focused. I like putting Lego together, I like taking apart things, putting things together. So I knew I couldn't be a lawyer.
Yeah.
And so by default, I did medicine, but without really any idea. I didn't have any relatives that were doctors. My parents weren't doctors, so forth. And so I really didn't know what I was getting into. And then I guess gradually you just get to know anatomy. I start liking anatomy. I like dissecting. I enjoyed the idea of putting, again, similar with a body like I was doing with Lego or cars and things like that, putting things together, and then sort of chose surgery rather than physician training. And then it's by default, I guess you learn that you do general surgery, neurosurgery, cardiac surgery, and I sort of found myself more when I did plastic surgery. That was my personality. I liked the creativity of it. I liked it how it wasn't a cookbook approach. So you'd work with one plastic surgeon. They had one way of doing it, and then the next surgeon said, that's all rubbish. This is the way I do it. And I just love that idea that you can sort of impart your own personality into the field, and it's not so cookbook. You make people very happy. And so I ended up in plastic surgery, luckily. It's a long haul in Australia, you probably know. So it's not something you do lightly, and you got to be prepared for a lot of study, a lot of work to get there. But then, I got there, and like most of my colleagues, we absolutely love it. We kind of live and breathe the craft, and we love contributing to it and changing it, and again, putting our personality into it, and trying to provide some unique things that distinctly ourselves, like myself, would be different from someone else, and so forth. Yeah.
You're known internationally as a breast and body surgeon. I want to dive straight into torso types. We've got short, medium, long. How does your approach to torsos differentiate from other plastic surgeons?
Yeah, so when I became a plastic surgeon, I started training, and I really had an affinity for this area here, so breast and torso, and what I noticed is that there was breast implants, most common operation in our field, and the way it was done and the way it was taught had no regard to the torso at all. So, average patient would come in and they want breast implants put in, and then our fraternity had the solution of, well, we can create room by, if they have a small breast, we can lower the fold and create as much room as we need, because you could just keep lowering the fold and create enough room. You can't go up too high because it'll be in the neck, but we can keep going down and just create enough room to put a template and make as big as breast the person wants. So people were just getting bigger breasts. You had the Pamela Anderson days, and these torsos were getting shorter and shorter and shorter. And, there'd be women just competing on how big they wanted. Surgeons in LA saying, look, I've done a 1,000 cc implant and a crazy custom-made 1,500 cc. And there was always a competition. And this whole time, the way they did it was stealing torso, what I call torso steal. And so it kind of, I came into the industry with these women and these spokeswomen with these very large breasts and no torsos. And I kind of thought, just aesthetically, just looking at it, you got to step back. A little bit like lips in your world, where people just went berserk. Look how much I can put in. I've put in 4 ceriac. Oh, you've put in 5 ceriac? Well, I can put in 6.
I think this was around 2016. Everyone went crazy on the bigger the better.
The bigger the better. And with us, the casualty I like to say is the torso. So as the torso gets short, people tend to look a bit frumpier. They don't fit clothes as well, and the clothes that you wear tend to be more balloon out. If you think of just, Humpty Dumpty, we grew up with, the reason he looks like a ball is there's no waist, there's no torso. So if there's one curve of the breast and that connects with the curve of the waist, and there's no separation, there's no that hourglass in between, that waist or torso in between, it starts to look more like a ball. So we lose shape, you look frumpier, you look chunkier, girls say. And so I started to sort of think, look, how can we get a really nice breast shape but preserve torso? In fact, even enhance torso, maximize torso, because we tend to lose torso as we lose. And then I realized really quickly there's different types of women in terms of their torso. There's short torso women where most of their height's in their legs and their torso is actually very short. There's long torso women, which is great because you've got all this play field and sometimes their legs are quite short. And then there's a neutral torso where there's a good balance between how much torso is and how much leg length there is.
I have a long torso.
You are very lucky, Alex, because
Thank you.
you have a long torso. Supermodels have long legs and long torsos. So with long leg, long torso, you're going to age incredibly well. Long torso always looks young. It looks great in all clothes. You always look slim, slender, stretched out. But when you're a short torso, and there's a lot of women out there, they're just born genetically with a short torso, and they have a lot of long legs. They've got very long legs, and they'd often, show off their long legs in clothes. But the torso, there's not much to it. And that group in particular, if you see someone like that, or I see someone like that in my practice, my top goal is to, whatever I'm doing with the breast, whether it's a breast lift or implant, whatever, any work at all, I'm going to try to maximize that torso and try to even make it a bit longer if I can.
So if someone has come to your practice and has had surgery previously, how do you correct that torso preservation?
Yeah, good question. So that is one of the most common reasons why I would see a patient for a revisional operation. So they've had implants. Commonly they're oversized or they're smooth coated, so they tend to drop. Or just the fold, their breast fold has been overlowered and their torso is short. And that phenomenon is called bottoming out. In other words, where the implant has either by a surgeon decision or over time just ended up too low on their torso. And the solution is an internal support system, which we call an internal bra. And that's how the internal bra kind of came about. And now, and any surgeon who's watching this, listening to me talk, they know with internal bra or internal preservation to preserve that torso. I do it with every case now. So whether you have a breast lift or I do some sort of repair to the internal support system of that lower fold of breast to keep that torso high.
Talking, patients that are listening or people that are listening to this part of the podcast, what is an internal bra?
Okay, so internal bra can mean different things. So basically, in my definition, is anything that supports the lower pole of the breast. And I like the term because if you think of an underwire bra, if it's got that big wire which goes like a U along the lower pole of the breast, if it's fitted well, it should follow the whole lower pole of the breast. And that is the interface, if you like, where breast ends and torso starts. And so if you do the same thing inside, whether it's a stitch or a mesh or something, we call that an internal bra. So patients love that term and surgeons love that term because it's just very easy to understand. Now, what does it actually mean? In most patients, for me, it's just a barbed stitch. And a barbed stitch is quite clever in that it's a stitch that dissolves over time, but as it dissolves, it's replaced with your own collagen, with your own scar tissue. So it takes a long, long time to dissolve, but there's little barbs trigger an inflammatory response. And inside, once that barbed stitch is gone, or dissolvable barbed stitch is gone, you've got a matrix of collagen, which is like an anatomical barrier to stop an implant bottoming out or just to stop torso slowly being stolen by natural breast tissue or just aging.
And does this internal bra result in a more perky breast?
Well, that we are just talking about the breast-torso interface, which is the lower pole of the breast. Your breast can still be hanging over it. So the breast skin, so if you think of the breast, it's sitting on the chest plate like that vertically. It ages like a slinky. So that's the base, and then it just falls over it. What we're talking about is the bottom of the slinky. So we can still move the bottom pole of that breast, or the IMF, the intramammary fold, up and down with internal bras, but we can't prevent the skin aging over it like a slinky. That still requires a breast lift.
Okay, which is a mastopexy.
Which is a mastopexy, yep. So if someone comes in and says, look, I have low breast, the first thing I see is this really a low breast or is this torso steel? Is the implant too low And what's actually happened is the implant slid down, so it looks low, but the skin of the breast is still fantastic. It's tight, the nipple's in the right position and so forth. That doesn't need a lift. So that can all be done internally through the old scar. Just the torso has to be extended.
Do patients that have had children require a lift more commonly?
Yeah. So once you've had kids, both age, so both the breast torso interface, or that lower pole of the breast, comes down, but more commonly the skin of the breast as well, because it gets expanded by all that milk which comes in and comes out, slinkies down as well. So their inframammary fold is a bit lower and their skin's lower. So they need both. They need an internal bra and a lift together. That makes sense.
Yes.
Yep.
You talk a lot, I've heard you speak about the breast and the torso being a continuation.
Yep.
When did you really start to incorporate this into your practice?
So probably it's been mainly over the last 10 years. I mean, I just noticed it, and then I just realised that whatever work I do on the breast or whatever I do on the torso, because with aging we tend to lose torso and gain breast footprint. I'm always trying to extend that torso and keep the breast on its original footprint. So probably over the last 10 years, and it's a combination of techniques, including the internal bra and just the way I reshape the breast or would do a tummy tuck abdominoplasty procedure, trying to get that torso interface higher. But I guess the main thinking is just to, every time someone comes in for any breast work, you can't make a great decision over what you're going to do unless you look at the waist as well. And it sounds obvious, but people didn't do it. They just looked at the breast. And in fact, all the teaching to all the surgeons out there, they would just be a snapshot of the breast. And you still see before after, it's just the breast. Well, what's underneath it, and they'll say, well, lower the torso here. And there wasn't any thought really given to what's left behind. Instead, think of the whole thing together. We can make this more aesthetic or bigger, but at what cost? Is it worth the cost? And so I would often say no, because what someone might be asking for at wish list won't look aesthetically great, because there's a cost, and that cost is often torso.
We touched briefly on women that have had children.
Yep.
A common procedure would be breast surgery and abdominal surgery at the same time. Can you talk us through that process?
Yeah, so that's become really common. Obviously, the pregnancy process, the weight gain, the weight loss, the breast stage, the slinky effect of the skin coming down and the torso drop. And at the same time, the pregnancy separates the muscle. The ribs also separate, because as the muscle separates, people don't realize, but that rectus muscle, those ab muscles, they're attached to your ribs. So as the muscles separate, the ribs separate. And so you do lose the curvature of the waist.
Yes.
Plus, many have so much separation that they can get a hernia, which is basically a rip in the muscle, and they continue to have that pregnancy bulge on profile. So it just became common to ask to do both together. And I do these every Friday, as people know, here locally. And it's a great one to do together, because you can consider both at the same time. Like, for example, if someone's got a lot of separation and you're going to tighten their waist a lot, well, our decisions over here, we may not need quite the same sized or width breast, because our waist is going to be smaller. If we know we're going to be a size 6 at the end of this, it's pointless doing a very wide implant, because then they're going to be wearing size 12 bras. It doesn't. You start to make decisions together. And so that's why it's a powerful way to do the surgery if you know you want to do the abdominoplasty, the tummy work, and the breast together after pregnancy.
How long after, you've decided to stop having children and your family's complete, would you consider having this type of procedure?
So generally, you want to stop breastfeeding for at least 3 months. So these days, people can breastfeed not at all, or they could breastfeed for 2 years. So that's a big determinant. So you really want to just be completely dry, let all the milk go away, and be dry for at least 3 to 6 months, we'd say. That's the first factor. The second factor is you want to be at your most shredded weight, and we can talk more into it. But there really is no point doing anything like this. And this is a big surgery.
Yes.
It takes the whole day, big team, a lot of planning. Usually I see someone, by the time they have the surgery, it's usually close to 8 months to 12 months. So that's our average time from having a consult and having a combined procedure. And during that time, we're shredding. We're trying to get to a lean body weight.
Exercise?
And why? Exercise, diet, sleep, the big 3 pillars. So looking at your diet critically, trying to go more keto, avoiding junk carbs and starches, supplementing what's needed, and building up muscle, exercising, getting lean. As after pregnancy, as that weight drops off, as that fat sort of goes away, more loose skin forms. So you find new folds, new ripples, new bits of skin hanging on the tummy, and the breast drops more. Sometimes the areola gets wider and so forth because the skin, with the lack of that subcutaneous fat, starts to get stretchier. We want that. People get kind of put off and go, oh, look, everything's looking worse, but that's what we want. We want all those kilos to go, you to be at your absolute fittest before the surgery. So that takes time. So people say 3 months after pregnancy you can have this combined type of surgery, but it's not the time. It's really how long will you take to stop breastfeeding, shred, get to your fittest, and sometimes it's years.
I think so. I mean, after my 3rd baby, I went back to work very quickly, but it took me at least 12 months to start to feel normal again. The hormones settling and stabilizing, getting a good routine, especially if you're working and looking after children at the same time, prioritizing your health.
Yeah, exactly.
So are you obviously very comfortable in turning patients away if you don't think they're healthy?
Yeah. So it's not that. So I think I must be the only plastic surgeon anywhere that does a body composition scan on everyone, especially the people post-pregnancy women who are after combined procedures, and I find them really useful. So if you haven't had one done, we use InBody 770. You stand on it, it pushes electric currents through your body, and it basically gives you a fat percent, muscle percent. It tells you where all your muscles are, where the bulk of it is, and it gives you kind of a health rating in terms of your body for your age, for your height, and so forth. It's a good starting point, and then we can use, because you've got metrics and numbers, we can kind of say, well, look, you don't have enough muscle. Look, your legs are lacking. Why don't we start doing some squats, some basic things, get a personal trainer, and at the same time increasing their protein intake and decreasing their carb intake. And when they see the metrics, people respond to it. And so it's not really turning them away. It's sort of saying, look, you're going to be a good candidate one day, but not now. Here's what we want to do. Come back, scan yourself anytime you want. It's the people who travel. I do get a lot of travelers. Probably half my patients aren't from Sydney, but there's always an InBody scanner nearby, and they've got an app, and you can just track your performance kind of thing. So and then when you get to ideal, you get the right score. We say a score on that InBody machine, if you're not over 70, 75 is great. Then you're an excellent candidate, and you're kind of really mitigating against any undesirable, unfavorable healing issues or scar health or anything like that, because you are a machine. You've got a lot of protein stores. If your scars remember, scar is 100% protein. We have the inflammatory markers are all low because you're not eating junk food and sugars and things. And so your body's a healing machine. And so once your score on InBody is over 70, 75, we know you're going to heal well, and it's a really good investment. And luckily, it's exactly the same investment in your own whole lifespan. It's the same things that will keep you happy and healthy and living to 100, So it's a perfect time, I find, to address all these things before your surgery. And so it's not really turning away. It's sort of saying, look, you could be a great candidate, but let's address each of these issues. And people are disappointed. They think, well, they may have seen another surgeon. They say they can fit them in next month. And I say, see you in 9 months or 10 months.
Yes.
But the reality is, I want to, I want the best result possible. They want the best result possible. And I know for a fact, and we've got so much evidence for it, they're going to be in a much better healing state for such a big surgery if they go down this protocol.
Being a breast and body surgeon, curves are very important, and women and men alike love cleavage.
Yeah.
How have the innovations and techniques changed to create that beautiful cleavage and curve?
Yeah. So, cleavage lines is another, again, anyone who knows me, is another pet topic for me. Cleavage lines are interesting in that, again, with breast work in the breast world, when I first became a plastic surgeon, if you looked up cleavage lines and a surgeon, there was nowhere. No one talked about it. And what I found was most of my patients, because I live near a beach and a lot of my patients near beaches, their ideal look would include somewhere displaying unsupported cleavage lines. So obviously you can always create a good cleavage line with the right bra, you can push things together, you can use fillets and so forth, but unsupported, so say you're wearing a plunging neckline, a summer dress with a plunging neckline, or a bikini with, you're hardly, not tying it up, or a backless dress or something and starting to show cleavage. Tight, close cleavage lines, you got to think about that, because if you just do implant work and don't think about it, you're going to get the generic big, wide gap. It's two big lines. It's that 80s look, in Miami Beach. I would say Miami Beach, 1985. You just look around and everyone's got a gap this big. And they're both very straight, unnatural lines. And that's, you see people going, that boob job. So everyone doesn't want that. And so people, patients would mention it. They say, look, I like these cleavage lines and I don't like these cleavage lines. And I realized we've got to spend some time thinking about how can we do this. And luckily now, with the advent of fat grafting and also playing around with dual plane interface and anatomical implants, we can always get closer cleavage lines. We can always get aesthetic cleavage lines. But it's something you need to think about. And so that is a lot of my work. A lot of my work would be improving cleavage lines and getting people into kind of that braless, plunging neckline look where they can be confident.
I get this question so often about fat grafting.
Yeah.
And, how much do you retain? And a lot of women do not want an implant.
Yeah.
But some people need an implant.
Yeah.
So can you take us through fat grafting and how much does the body hold and how much do we lose?
Yeah.
And why do some women need to have an implant? Yeah,
so that's a good question. So fat grafting, as soon as you research breast work, you'll see fat grafting come up. The answer, I guess, depends on how you use the fat. So fat grafting is feature probably, I'd say now, 90 to 95% of all my breast work. So whether you're doing a lift or anything, so it's almost like a tool. So, it's like saying, pass me the knife, or I'd say pass me the fat. You need it to almost airbrush the result. It's almost like airbrushing. So you've got an implant or you've got your breast lift and the décolletage looks too crepey, a little bit like, aged décolletage or burnt décolletage. You've got this rejuvenated, natural-looking breast, but the décolletage looks depleted. Well, I'm going to put fat in there, just like you would in the fill in the face, because part of the aging process and sun exposure on the décolletage, which is kind of part of remember, I think of here to here as one. So there's no point, getting a nice nipple and the breast in position and the décolletage looks very old because it's going to give it away. So we need fat. Implants not going to do it. Breast tissue is not going to do it. We need to put fat in that subcutaneous layer just like you would in the face and make it look thicker, tighter and younger.
And where will you get it? Where is the best fat part in the body?
So the best fat is the inner thighs.
Okay.
So you will see surgeons saying, I can take it from the inner knee and all these things and, the back or the buttock. But I've done so many thousands of fat grafts now and the best take is inner thigh fat. Close second in many people is the lower tummy. So I pretty much only graft from those two areas because I know it's going to be a very reliable take. And the other important fact with fat grafting is it's the amount that takes is based on quantity. So if you're, for example, planning to do a mega volume fat graft, which I don't do, say to hundreds and hundreds of grams, yes, overall your take could be as low as 40% and you'll get oil cysts and all sorts of problems.
Right.
My typical amount of fat grafting is 100 to 150 grams a side, sometimes even 80 grams. So there's small amounts. So if there's small amounts from the inner thigh and they're injected not into the breast substance itself, but just into the subcutaneous layer, then if you think about it, it's just like subcutaneous fat grafting anyway. Like it's like me injecting subcutaneously in the cheek or in the hand, Now, these areas, they have incredibly high takes because the fat graft is right under the dermis, and the dermis has such a good blood supply, we know it's going to do take. So I have the same philosophy here. If I go just under the dermis, the take, I expect it to be 80% plus.
Yeah, wow.
Very high, because we're right near the skin. As we get away from the skin, we're away from those dermal capillaries, and we're relying on the breast tissue to sustain that fat, it's not going to work. Half of it's going to go, and it can form oil cysts, mammogram, it goes. And so I don't do that. I just do subcutaneous fat grafting in 90% of people, in the décolletage, in the cleavage lines, lower pole, everywhere in the breast, but it's in that subcutaneous layer, not really in the breast tissue itself. Very, very superficial.
So if a patient had breastfed her children, has significant laxity and was requesting only a fat transfer or fat grafting from you, how do you talk her through that next process if she needs a mastopexy?
Yep. So I would say, she still needs that mastopexy. We need to do it. But all these areas that are super crepey, particularly if she's thinking of implants as well, we're going to need to, there's no point just repositioning that skin. That skin is aged skin. We need to rejuvenate it with some healthy subcutaneous fat, which we're going to get from inner thighs. So I would extensively fat graft that area at the same time mastopexy. But I would also tell her that we're not using the fat as volume. So I don't very rarely use the fat as volume because of those reasons that I've said. So if we do too much, it's not going to work. It's not really going to give us what we want. It'll only give us problems. And really, aged fat, it's not going to magically stay up and give us great cleavage lines or great upper pole. We need an implant for that. We need something that's not you, because we can't make fat perform miracles. If you couldn't do it in the thigh, it's not going to do it here. So if we put any fat there, it tends to drop unless it's very young. So I don't use fat really for volume. So we're going to rejuvenate the breast with a lift, and we're going to airbrush it with a fat grafting to make it look younger on the surface. And then if we need volume for the upper pole or cleavage lines, we're going to use an implant because we know it's going to be reliable and it's going to give us what we want.
We've sort of briefly touched on the menopausal age group and women that have had children. Varying ages, let's talk about the 20s and the 30s. How are their needs different? And how do you go from breast surgery in the 20s and 30s before children?
There are certain age groups definitely that you would see in a consult, and the needs are very different. So post kids, that group, I've never even thought about plastic surgery before in my life, and then I've had these kids, and look at me, I just don't feel, it's a shock, and I don't know how you women do it. It's amazing, with as a guy, you're always in control of your life. You just go to the gym, or you just put down that beer or whatever it is, and you see the change.
Yes.
And then with women, you could be as healthy as you can, doing everything right, and then you have a pregnancy, certain genes kick in the wrong way and stuff like that, and then suddenly you look at the body and you just don't recognize yourself.
I think the skin laxity is the biggest shock, specifically in perimenopause. Everything's fine one day, and then the next moment it's like, how did this happen so quickly? It's that balancing that estrogen. So the skin laxity is a real issue for the older women. Yes,
it is, and again, it's you can draw the right straw in the wrong one. If you're genetically blessed, and some women go through that perimenopausal period, and their genes are just the right way, and they don't get the same skin laxity, or they have. But others, they really see a difference very, very quickly.
I think for me, the penny really dropped on the weight training. Like, it is just imperative in the 40s to start seriously thinking about weight training and building that muscle, specifically in the leg area for that skin laxity.
Yeah, absolutely. So think of your muscles as a big store of protein. So if your body needs protein, and remember, protein, people used to think protein is just, colloquially, just for muscle building. Protein is everything. So your skin is all protein, your collagen is all protein, your bones protein, everything's protein. Protein are the Lego blocks of your body. So if you lack protein, your body has an altered capacity to heal things, to stay young and so forth, because your skin is way down the priority of what your body thinks is important. It's looking after your brain, your heart, and so forth. You want a protein surplus. And as you get older, because we tend to lose muscle, called sarcopenia, as we get older, we need to up the training up the weight training, resistant training, and up the protein levels. Before surgery, I tell people to get to normally, for maintenance, 1 gram or 1.25 grams per kilo is okay. But before surgery, I tell people to bump it up to almost 2 grams per kilo, because the protein requirements of surgery, particularly having a lot of surgery, lift surgery, tummy tuck surgery, and so forth, it's a lot of cuts, and the amount of protein you're going to need for that. But if you have big muscles as well, then your legs, why legs? Because the legs are just such big muscles, physically big. Your buttock, the gluteus maximus, biggest muscle in your body, the thigh muscles and everything, very large muscles. So they look great, and they're huge protein stores. So your body has those ready to roll.
Going back to the girls in the 20s, really want to improve their breasts, but may be considering a family later on. How does that affect them if they go ahead with the surgery in the younger years? It's a good question. So it depends how close they are to having kids. So if they see you in the early 20s, and look, kids are just something that happens far away, it's not nowhere there. Because the nature of implants is we usually have to revisit them somewhere between, say, 10 to 12 years in most people, because they just get old. There's new technologies that can break and so forth. We think 10 years ahead. So if 10 years ahead, they're still not going to be having kids, or it's not going to happen in the next 10 years, you can pretty much do what you want. I mean, look, they're the golden years. You're young, you're bulletproof, you don't have sarcopenia, your muscles aren't getting smaller because you're not exercising. If you don't have enough protein, your body deals with it, and so forth. So those early days, you kind of have a little, as a surgeon, you kind of more go with what the patient wants, within measure, to make sure it looks good and so forth. But we're not thinking so much about later, because once they go through a pregnancy, who knows? We don't know what they're going to look like then. It's so far away. However, if they're having surgery and they're in their, say, late 20s, they're in a stable relationship, they're thinking about kids in the next 2 or 3 years, then it gets very relevant. Okay. So you want to kind of make decisions that will make them happy, but at the same time isn't going to suddenly all break down after the first baby. You want them to be able to go through as many kids as they want without having surgery again. And so that's where you start telling people, no, not that big, or let's just do a lift. Don't worry about the implants. We'll just focus on creating a nice, small and natural breast, because we're expecting with your genetics and, your parents and talking to your mum that this is all going to drop again. You start to think, yes, let's do it, but in 2 or 3 years, it's all going to change. And we're trying to minimize the change to get them through all their pregnancies before we do it again. I really want to talk about explants, because we have seen it a lot in social media. Have you had a situation where a patient really wants an explant and then, has had breast implants for 10 years and really used to that fullness, and then come back to you, 3 to 6 months later and say, I actually want my implants back in?
So good question again. So explants, yes, sometimes women for whatever reason want them out. And the first thing I do is we really want to get an assessment of what's left inside. So if they had implants for many, many years, they've even can't remember all the changes they've gone through, their weight might be different and so forth. So I find MRIs are quite good, A, to assess the implant and just see what you're taking out, but B, to also get an estimate of how much breast tissue is going to be left. And so we can talk about it, before we do it, and sort of say, look at this MRI, you're all implant, just skin.
Yes.
And so when we take this out, you are going to be completely blank. Like everything's going to go back to square one, or even worse, because if you've had a very big implant, sometimes because the cartilage of the ribs are a bit like teeth. So, with orthodontics, you push teeth together and they move. And same with the cartilage of the ribs. If you have a big, heavy implant sitting there for a long time, the ribs sometimes hollow out. And so when that happens and you don't have breast tissue, you actually concave.
Yeah, wow.
A little bit concave. So I have that discussion before, so we know what's going to happen. Often though, what's with explants, they happen later in life, and the patient may have had some kids and there's already some breast tissue and it's actually ptotic, it's sagging a bit. And then in that case, you would be taking it out and reshaping the breast tissue they have and making that kind of replacement. So that's a common thing. But if they're going to be left with nothing, we have a big kind of talk about it, so they're going to be ready for it. To avoid what you said, which is basically, oh my God, I didn't realize I'd be this small.
Sure.
In fact, I can't wear anything now.
Sure.
Everyone's identified me this way. I can't even hide it with padding now. We're going to have to put something back in. And no plastic surgeon would want that. You'd want kind of, if you are doing some sort of 2-stage operation where you're doing out and in, and that happens for various reasons, you're doing it as a planned way. We're going to do this. We're going to let the skin retract, and then we're going to put a small implant in, for instance. But not surprised, kind of, oh, let's put the implant in urgently. No surgeon would want that. Yeah.
We've talked a lot about what happens in the lead up to surgery of this kind and being in your best physical state in terms of your health and fitness. How long is the recovery from breast and abdominal surgery? An operation you would do on a Friday, more for the mothers and people that have finished their family.
Yeah, so if you're having combined full abdominoplasty, including the muscle plication, and then a breast lift, it's a long surgery. And what I tell patients is, yes, we've got that pre-surgery time where we're trying to get as fit as we can, as lean as we can, ticking all the boxes. And then the post-op is exactly a continuation of that. So there's no bed rest, zero. So right from day one, we have a physio that walks you immediately. So for the next 3 to 4 weeks, we tell people to be off work, but not for bed rest. It's a major rehab. I mean, you're up every hour.
Wow.
And so I find if you go to work too early, you're then back on the desk 6 hours not moving. And so the body's not moving. You've just placated the abdominal muscles. You made the waist. And without the muscles moving, they start to get stiff and they ache and you bloat.
Oh.
And so I find you need 3-4 weeks off, but not for feeling sorry for myself and ringing the bell and pass me this and look after me. It's so you can rehab. So we get people walking straight within 1 week. They're in hospital for 3 nights, but during that time, it's pretty rigorous. The physio's there, the nurses are there. They're walking them up and down steps. They're walking up and down the corridor, encouraging them to go out. And as soon as they're home, we're talking about a couple of hours walk all the time. Like every hour, I tell people for every hour you should be getting up.
I want to talk about that. So you just said walking straight.
Yeah.
So post-surgery, the patient naturally would like to sort of hunch over to protect their abdominal area. Is that what you mean?
That, and also the skin, lax skin is a funny thing. It's not like in architecture, we've got a static material, it's living. And so with tummy tuck work, if you cut out just the right amount of skin to make it a flat tummy, within 1 week, it's already too lax. We've got to cut out too much in a way. And to protect the repair, we keep the patient bent. In other words, working bent and so forth. And it'll take them about a week to kind of stretch that bit of skin out. If you cut just the right amount of skin like you would with a mini and they can walk straight away, there'll be laxity within a week. So overstretched skin, it's programmed to keep stretching. So it's almost like the body's, you've had kids and it's programmed to have more kids. So it's ready for milk coming in. It's ready for a pregnancy. So us pulling on it mimics biology. And so the skin just says, well, I'm just going to stretch out some more.
Okay.
So we have to overthink it and kind of take more. I'm anticipating to take that much, but we're going to take that much more because we know the body's going to stretch it out. And same thing with breast lift work. We have to kind of think, yes, this looks perfect on the table. I'm very happy with it, but I don't like that, fold here. It's going to become a fold within the next few months. I'm going to tighten that extra strong because we know that skin is going to stretch. And that's why, they're kind of walking in a protected bent over position. And within a week, we get them straight because it's a lot of strain on your lower back.
And how many nights in hospital do you recommend?
So typically 3 nights, 2 to 3 nights, depending on how they feel. They've just got to be comfortable, doing things. And a lot of patients related to a Caesar, even though no skin's removed in the Caesar, it's a relatively simple procedure. We've got to get the baby out. There's a little bit of bent over there, more because of the muscle ache, and there's a couple of night stay as well. So it's kind of like the Caesar experience, but a lot more movement.
Going back to breasts, patients are requesting, and the buzzword seems to be braless technique. We've touched on cleavage. Can you talk us through that?
So I guess the word braless look is something, again, that started in the beaches. I just find any plastic surgery colleague who has a practice near a beach, most of their patients, again, regardless of what breast work they want, whether it's implants or non-implant work, would want something that looks good with or without a bra. And I think that's really been cemented because of the social media. So you've got all the influencers. I mean, if you look at any gala night and any awards night, everyone's wearing backless, strapless dresses and the plunging neckline. And that is very hard to wear a bra with. I mean, you can't, like, how do you make it work? You're going to show these bras and so forth, and just kills the whole look. So part of the wish list is going to be these summer dresses. And what it means for a plastic surgeon is we have to kind of translate that into a result. It means more support, more support, more support. So with implants, as we talked about the internal bra, we can't get enough support down below because it just means there's always something holding that implant even without a bra. And where the cleavage lines, we see them, they're hopefully going to stay there long term. And you're not going to be relying on the implant being pushed up by an external bra. You've got something inside. With breast lift work, the same, trying to get that torso visible, getting all the skin. So with all breast lift work, as a standard, all skin of the breast can't touch the torso. We can't have any contact. Again, this seems obvious, but before this braless world took off, particularly the vertical technique of breast lift surgery, it always leaves skin on the torso. So day one, you've got skin on the torso. The nipple's in the right position, but there's still a lot of skin on the torso. And that's fine if you're going to wear bras.
Yes.
But it doesn't look good in a braless look because, again, you've got these cleavage lines that go all the way along the torso. So, again, your torso looks long. The cleavage lines are too long. Torso looks short. It's anesthetic if you're not going to wear a bra. And so I guess all my work and all my patients is kind of now focused on this sort of braless look. And that's why, with all breast lifts, there's never any skin. I tell patients, this skin will not touch this skin, and on the side you won't get that fold because I know that might be showing in a dress. There might be a window there or a window there where we don't want to see any skin contacting. And so, the braless sort of buzzword has crept in, and it's a modern thing. Again, in the historically, and when I was learning plastic surgery, this was not a thing. It's really it's crept up through social media, and particularly young girls, size 6 to 10. Of so many dresses and so many things are designed without a bra.
Speaking about, you're an international speaker and you share your techniques all over the world at different educational meetings. Who was your mentor? How do you get better?
So I guess it all started when I first became a plastic surgeon. I went to Europe and I worked with the guys in Sweden. I thought they were really innovative in their approach, and they had metrics and data and so forth. People like Per Hayden, and then I went to Italy, France, and worked with mentors, and similarly with the US. And luckily, I've got a network of other surgeons who specialize in this area, sort of breast torso, and we constantly exchange ideas and measures. And it's interesting. Like sometimes we have completely different views, and it's not that anyone's wrong. It's just we live in different communities and we have a different patient. My patient's like this, their patient's like that, and it works for them and it works for us. And so I think it's really important keeping in touch with people around the world and not just being in your little bubble, because you can get so eccentric on one type of result or one type of operation, you sort of forget the overall scheme. But there's a handful, 10 to 15 surgeons who have a very focused practice like I do, and have a very similar mentality. They keep fit, naturally, and they just have very mentality. And so we exchange thoughts all the time. I think you just interviewed one.
Yes.
So in LA.
I did. I interviewed Robert Cohen, who spoke so highly of you.
Oh,
and
thank you.
He had a wonderful time here in Australia at one of the Melbourne meetings, I think.
Oh, okay, great.
So I have convinced him to come back to Australia again. But I do talk about that all the time with other clinicians, even in non-surgical, in the non-surgical arena, because our work is so visual. Like we have to have that aesthetic eye. And, I often get asked, why do you travel so much? I stand in rooms in LA or London or New York watching other people inject, because I will learn something in that room that is going to make me better. Yeah. So you have to see other clinicians in action and share ideas, because it's changed so much, and it changes all the time. Yeah. So I think it's really important to develop those relationships with colleagues, Do you agree?
Absolutely. Yeah, and this is why we have conferences, and I speak in conferences and I do masterclass and webinars, but it's amazing how much you learn out of each of those, because you start going down a line of questions, and you go, I didn't think of it that way, and I didn't think of how they could do it, and it's only because someone's triggered a question or something like that. And so it's the nature of conferences to do that, and it's why we always have a good time and come out wiser out of it.
You've built such a massive following on social media for so many years. Talking about, evolving and getting better as a plastic surgeon, what is next for you?
What is next for me? Well,
it's always a tricky question.
It's always
one.
a tricky
I always
question.
trick people with this one.
I think our field has been changing a lot. I mean, just with breast, there's always going to be implants, and for example, implants. Every week I'd get emails from manufacturers with some new product or something they're working on, and so forth. So, just like your world, Alex, with fillers, there's always new products, because part of our work does rely on manufactured products, and just like cars, every year there's a new model. That's what I tell patients. I'm a guy. I use car analogies, so
they do. I've noticed that actually, Michael.
So there's a new model, and the new model has this and this and this, and so it's the nature of breast torso is that you've always got to be plugged in. It's not just implants, different stitch materials. For example, all these barbed stitches I talk about, for the inframammary fold, the internal bra, different types of meshes. I went through a phase of using a lot of meshes. Now I've gone to barbs. But look, maybe there's a new mesh coming out, and I'm talking about a couple of new ones that I'll start using again. With tummy work, again, the sutures you to placate or make that waist, again, there's a lot of technology in that wasn't available 5 years ago. The current stitch I use is a permanent barbed, which is a very thick, what's called number 2 stitch, and it has 2 needles and gives a double layer repair, and it's just such a strong repair. I'm happy I'm happy for my patients to start Pilates ASAP.
Yeah.
Whereas before I couldn't because the stitch material wasn't there. So because there's so much technology in our field, and I have not even touching the technology in just getting yourself better and all the supplements and nutrition and all the preoperative stuff we were talking about. You've really got to stay on board with all of it, because every year you modify your technique slightly. Sometimes it's a very big change, but more often it's every year just slight modulations, and then you look back 10 years later and go, wow, I'm doing completely different things again. So yeah, I guess the nature of it, you have to stay plugged in.
Yeah, more of a business related question, because you've got a great team. I've spoken to the girls many times. How do you? Sorry, I'm going to go again. More of a business-related question. You've got a very strong team at your Bondi Junction practice. Patient-centered care has been such a focus of yours. How do you work with your team, really making sure these patients are cared for properly from the admin side? Talk us through that.
That's always a challenge. I think any business owner would say staff is right up there. Like it's always a challenge, because from your point of view, you're not there with the patient the whole time. You're not there when they check in and when they first meet the team and so forth. And you want their experience to be excellent. But at the same time, you want your staff to be happy, because if they're not happy, then it will reflect in other ways. And so we've always sort of maintained a very vibrant, young, enthusiastic team, and we're all friends. It's basically a small business, and so we're all friends, and if we all look after each other, if someone's away, someone does that. I'm happy to take stitches out and things like that still, if the nurse is away. I guess my philosophy is always, we've been very staff heavy, so we usually have 3 receptionists, where there's always a nurse, and by having more staff there that are in it, I just feel that there's a tendency to spend a lot more time with patients answering questions and things like that, and I encourage them to spend as much time as they need to. This is such personal stuff, and if anything's lacking, we just have monthly meetings and sort of bring it up. But my retention rate's pretty good. I mean, most staff stay for years, pretty much until they have a baby, and then they come back part time. That seems to be the way. But but yeah, looking after the team is a big priority for me, because I'm just aware that I'm there for the surgery, I'm there for the consult, but there's a lot of time that is spent with my team, and so as part of the journey and experience and all this preoperative work we talked about, they're the ones that are kind of tracking. How's your
Yes.
weight going? Can we help you? Because I kind of say, look, you need your weight here. We need to reduce the body fat percent. You need to work on your legs and this sort of thing to get your operation. But then they're the ones that actually follow it up and start saying, and then kind of say, oh, Miss So and So is getting ready for surgery. She's hitting the skull. So there's a lot of background work.
Yeah. You do such beautiful work, and it's been such a wonderful chat here today. Dr. Michael Miroshnik.
Thank you very much for having me.
Thank you.